So wait just 1 or 2 minutes for the people to join.
Okay.
Okay, I think we'll start. The others will find us already in. So, okay, thank you very much. My name is Clement Nyirenda. I am the e-research director at the University of the Western Cape, working in the office of the Deputy Vice Chancellor for Research and Innovation. And we have been working closely with Taichung Veterans General Hospital for some months now. We had the first webinar in March, 26th March, focusing on smart hospital innovations. And from there, we decided to have a second one, focusing on precision medicine and regenerative medicine. So we have 4 presentations that will take place now. And we will go through all those 4 presentations in the next 2 hours or so. And because I am not smart in terms of medicine, I don't know much about medicine. I know about computer science, artificial intelligence. So this webinar, I will hand over to my colleague who is an expert in pharmacy and pharmacology and bioinformatics, chemoinformatics, who will be the host. His name is Professor Samuel Egie, and he will take over from now and he will take us through the presentations. So Professor Samuel Egie, over to you. Thank you.
Thank you so much, Clement. Good morning, everyone. I hope you can hear me clearly. All right. Thank you so much. It's a pleasure to once again meet you. I was at the first webinar and it was quite refreshing. So just to get into the thick of things, as outlined by Clement, there are 4 presentations, and after each presentation, there will be Q&A. So we advise that you please, if possible, to make it efficient, can you please put your questions in the Q&A session? Just type them in and I will read them out. If it's very burning question that I'm not sure you'll be able to speak, but we prefer that you put them in the Q&A session. All right, so let's get started this morning. I believe the first speaker on my list has been given is Dr. Yin Ming Cheng. My apologies if I do pronounce that wrong. Is in the Division of Allergy, Immunology, and Rheumatology, Department of Medical Research. And he will be presenting to us this morning. Just a few things about Dr. Chen. He is the CEO of Precision Medicine at Center and Director of the Division of Translational Medicine in the Department of Medical Research at the Chanyun Federal General Hospital in Taiwan. And he studied medicine at the National University in Taipei. I didn't want to pronounce that word. Apologies. And just another thing that I see highlighted here, he's a trained geriatrician. Geriatric disease is becoming a thing because of non-communicable disease that we have this at the Center of Geriatric and Gerontology in Taipei Veteran General Hospital from 2006 to 2007. And he has received his rheumatology training at the Division of Allergy, Immunology, and Rheumatology at the Department of Internal Medicine at the current university that he's working in from 2007 to 2009. And also he's a lecturer in internal medicine. With joy in our heart, we want to welcome Dr. Chen, and we are looking forward to your presentation. Please take it away.
Thank you, Professor Selman. And hi, everyone, and from the Western Cap University, and also for those friends online, I'm Dr. Yiming Chen. Today is my great honor to be the first speaker to share with you our experiences in precision medicine in terms of rheumatology. And my topic will be navigating new frontiers, precision medicine, and polygenic insights in autoimmune disease management. As Professor Samuel just introduced me, I am a rheumatologist. For those who are not familiar with rheumatology, we are the doctor who take care of patients with arthritis, with systemic lupus, and allergic disease. And the first slide, I would like to show you the concept of precision medicine in systemic autoimmune disease. There are several different categories of autoimmune disease: rheumatoid arthritis, psoriatic arthritis, systemic lupus, arthritis, and a bunch of immune cells has been involved in the pathogenesis of autoimmune disease. And we also know that the HLA alleles plays an important role in the antigen recognition for the initiation and persistence of autoimmune disease. So in our imagination, we may imagine that if we could do a genetic test, then we can predict which patient would get the disease, which patient may respond to any type of immune monoclonal antibodies or targeted therapies. But with the efforts of 2 decades in rheumatology, actually we achieved nothing, not like in the oncology setting. This is because that rheumatology is far more complex than we could imagine. It is determined, the pathogenesis of autoimmune disease is determined by both the genetic background and also the environment exposure. From the slide I show you is the data we just published using the National Taiwan Health Insurance Database. As you can see on the left-hand side is the parental autoimmune disease, and on the right side is the maternal autoimmune disease. In the middle is the offspring, the son, the daughter's autoimmune disease. And you can see both the autoimmune disease from the father, from the mother, could simultaneously contribute to the infant autoimmune disease. But different matches could exist between parents and the offspring. So it suggests a genetic background interact with a complex environmental exposure. From the proposed roadmap of autoimmune disease, in this slide I take systemic lupus as an example. You know that systemic lupus is manifest with different organ involvement in the skin, in the mucosa, in the joint, in the kidney, in the cardiovascular system. And we can do a lot of clinical assessment. We do autoantibody tests. But now we have the modalities to do RNA-seq, to do the flow cytometry to identify peripheral blood immune cells. And we can do in the high throughput cyto throughput. And we have a lot of immune target therapies. We can target either B cells, interferons, cell signalings, plasma cytoid dendritic cells, and also anti-cytokines. But how could we interrogate the immune system, investigate the immune system using both cell population infos from the RNA-seq and also from the protein level to help us to do a perfect precision prediction? That's still in the research area. In the clinical round, we cannot do any specific tests to help rheumatologists to make a diagnosis very accurately, not like that in the oncology setting. For the pharmacology, I believe Professor Samuel may be familiar with the pharmacogenomics. And in this slide, I illustrate the gene and drug pairs in rheumatology. In our hospital, we can test TPMD gene, which is the important drug for the metabolism of fibrins. And as a therapy, this drug is an immune suppressant, which is commonly used in systemic lupus. And for the CYP2C19, it's a major determinant of clopidogrel. And also for the warfarin, for the statins, for the interferons, for mTOR target therapies, for BBIs, for the uric acid lowering agents, a bunch of gene and drug pairs. We can do that test, and then we can imply which drug may be suitable, which drug may not be appropriate for the particular patient with a different genetic background. This is called the precision prescription pharmacogenomics. And in this slide, we do an illustration using our previous publication. We do a test called TPMD gene genetic testing. And you can see from the left-hand side, the Kaplan-Meier survival curve. For those patients who carries a normal metabolism of TPMD gene, is illustrated in blue, and the incidence of hepatotoxicity actually is lower as compared with those patients carrying risk allele in terms of DPND, which is the abnormal metabolism. So with the preemptive testing, we do a test before initiation of this drug. Actually, we can prevent the occurrence of hepatitis if we prescribe this drug to a particular patient. And also in our hospital, we have incorporated the genetic information into the prescription system. As you can see on the right-hand side, our IT system has incorporated the pharmacogenomic data beneath the prescriptions. So the physician could be aware of the genotype before they do a prescription. And we also pop out a questionnaire to query the physician whether you want to change the drugs according to the genetics or not. This brings additional information for our future education programs for our physicians and also our medical staff. Not only the azathioprine, but also methotrexate could be affected. The metabolism of methotrexate could be affected by genes. And these figures illustrate how methotrexate is metabolized in the intestinal lumen, in the hepatocyte, and also exert its effect in the joint. And methotrexate actually is the anchor drug for the treatment of rheumatoid arthritis. And on the right-hand side, you can see a bunch of SNP which have been reported to be associated with MTX metabolism. And our data, we have the chance to look at around 2,000 rheumatoid arthritis patients taking methotrexate. And we can then separate them into adequate responder to methotrexate or not. And then we have a chance to look into different allele frequencies of ABCG3 and ABCC1 genes. And we found that these two genes, three SNPs, actually is associated with methotrexate treatment response. So before we started the drugs, we know the chance is high or low. The patient may respond poor to methotrexate. This could help us to save money and to prevent unwanted side effects. And the paper has been submitted to the journal for review. In rheumatoid arthritis, we also use biologic agents. In this slide, I illustrate TNF-alpha inhibitor, which is a monoclonal antibody against three-fold or cell membrane bound TNF-alpha. And we do a deep sequencing for HLA, and we collaborate with another hospital nearby, the China Medical University Hospital. It is called China, but it's located in Taiwan. And the CMU and Taichung Veteran General Hospital, we work together to do a deep sequencing for HLA, and we find out 8 SNPs located within the HLA actually is associated with TNF-alpha response. And then we also find out allergic reactions to painkiller, to NSAID, actually is also associated with HLA. In the prescription system, the physician may mark whether the patient has drug allergy or not. And we have a chance to associate the drug response, allergic response to HLA sequencing. And we could identify several HLA alleles that have been associated with NSAID hypersensitivity. And this data has been published in the literature. I just finished the part of single genes, and then I will come to the polygenic risk. We know human disease actually comes from a complex hereditary pattern. But most of them are polygenic hereditary pattern. Now we have a technology to calculate at each gene effect. Each gene might have a small effect to a disease. We can calculate the effect size, and then we use machine learning model to sum all of the polygenic risk to form a polygenic risk score. And with the technology, we could see whether the patient is at higher risk of certain disease or not. And this year, we published a paper using our own data set. We enrolled around 2,400 SOE patients, systemic lupus, and we calculate our own SOE polygenic risk score using in-hospital database. And we discovered 27 SNPs that could be contribute to SOE development. And I believe in South Africa, in any part of the world, you should develop your own polygenic risk score, because genetic information actually vary quite a lot across different ethnicity. So we have a chance to look at polygenic risk score from Caucasians, and it works worse, not very good in the Taiwanese population. So we must develop our own polygenic risk score for a different disease. And with the polygenic risk score, we have a chance to categorize patients into high risk for lupus or low risk into lupus. And the risk from genetics actually is associated with the first year renal disease in this group of renal lupus patients. So actually it has its clinical value in terms of disease prediction, and we could treat the patient early. The disease, the autoimmune disease, affect not only human, but also our furry friends, dogs. And we have a previous study showing that dogs raised by patients with lupus, actually this dog had higher chance to develop SOE and higher chance have positive ANA in their blood compared with dogs raised from patients without SOE. What does this mean? SOE is not an infectious disease. So maybe the environmental virus infection could infect both the host and also the furry friend. So it suggests that we should identify the environmental triggers for the autoimmune disease. And then remember, I just mentioned to you, we could calculate the SOE polygenic risk score. So we have an instrument to calculate whether the patient is at high risk for lupus or not from the genetic point of view. And then we try to analyze whether the patient developed SOE from the disease onset. Is that because the patient exposed to too much sunshine, sun exposure or not? Because SOE patients tend to have skin rashes in the malar area, in the face. It is because the UV light could trigger the immune cascade beneath the skin. It can trigger the keratinocyte as an antigen-presenting cell. And then we have the patient's address, home address, and then we can link the home address to GPS data location, and then link to Central Weather Bureau, the sun exposure dose in the past 3 decades. And we find out that before the onset of SOE, actually the patient, if he or she has a higher risk, genetic risk, the dose need to initiate the systemic lupus. The sun exposure dose actually is lower. So it means that if a patient carries a higher risk of genetic risk, the patient should avoid sun exposure before the onset of disease. So this study actually has a preventive medicine implication. So we wrap up this study and this is in revision now. In the clinical setting, we will do an immune test called anti-nucleus antibody. We can stain the human Hep2 cells with the serum from the patients. And the patient, if they got the autoantibodies to conjugate to human cells to attack human cells, and the titer and the patterns of the immune fluorescence is associated with the onset of disease. And ANA test actually is incorporated in the diagnostic algorithms of systemic lupus. And we have a chance to use machine learning to help us in the algorithm of systemic lupus diagnosis. Because of the constraint of time, I don't have luxury to go into the details, but we use 6 types of machine learning models to see whether the ANA patterns, ANA titers, all the parameters in the EHR, in the electronic health records, and also the genetic variants and polygenic risk scores. Putting all of them together, we could establish a very good AUC for diagnosis of systemic lupus. And we have a chance to separate the patient into high titer and low titer ANA, and then we could identify several genetic variants and clinical parameters that is associated with the onset of systemic lupus or not. So this is the example of how we could use machine learning for patient stratification. But we need to put all the machine learning algorithms into our clinical the prescription of the ET system. We have a long way to go. And the last part of my talk, I will talk a little bit about a prospective study. Now we have the instrument to identify patients with high risk of genetic for lupus. What if we could see them before the onset of disease? So we encourage female patients, age 20 to 50, and they have the most dangerous, most top 5 genetic variant, genetic risk for lupus. And we enrolled 130 patients with high risk for lupus, and we took the blood from them. We do a lot of questionnaires, and we identify that for those patients with top genetic risk for lupus, actually some of them already developed some part of manifestations: mala rashes, photosensitivities, arthritis, fever, and the anti-nucleus antibody actually has been increased as compared with the random control patients. So with this technique, we could actually identify patients before the onset of disease. And we try to identify what is going on in the immune system before the onset of disease. So we identify those group of patients with pre-SLE, and we do a single cell sequencing. And this figure shows the neutrophils, different immune cells portraying with lupus, pre-lupus, and also healthy controls. And in this slide, I just pull up one preliminary data. We find out in the myeloid cells, in the lymphoid cells, actually in the viral signature in SLE, pre-SLE patient is increased as compared to the healthy control. So with the use of polygenic risk score and also in the viral signature, we could possibly identify those patients at risk of having this disease before they are onset. So now the question is there any drug, any preventive medicine we can give to them? I don't have the answer yet, so maybe we could find out the preventive medicine together. With the technology, we could also make money. So we go to the healthy checkup, the health management, the health checkup sites to do a genetic testing for those without disease, and using our own data from our own hospital. And as you can see, I apologize for the Chinese heritage, but we can now identify 27 complex diseases using polygenic risk score from our research. And we are trying to sell that to the healthy not patients, healthy people in the community from the Taiwan community. This is the last slide. I would like to conclude that autoimmune disease actually has family cluster. It implies a complex interaction between genetics and also the environment. And the integration of RNA patterns, electronic health records, genomic data using traditional statistics or machine learning methods, actually we could identify, we could improve the prediction model for lupus. And using the SOE-PRS, we may identify earlier for patients at risk, and we could ask them to avoid sunshine, to maybe avoid immune promoting healthy herbal food. With that, I'd like to thank you for your attention.
Thank you so much, Dr. Chain. Thank you so much. I'm not sure, organizers, if the Q&A is already open for people to type in their questions. Can the participant just go to the Q&A or the chat? Any of them, you can just, because I tried to look for questions, I didn't see any. Please do go to the chat if there are questions. Okay. You can just do that quickly. All right. Okay, so we're going to take questions now. I think if I don't see any right now. I might be the one to start if there's nothing. There's one question coming in. Okay, Monji has a question. Good. Okay, he's asking the genetic testing that you do, are these tests already validated? The one that you use in your hospital? Dr. Chen, do you want to respond to that?
Yes. And I think the question is whether the genetic testing has been validated.
Yeah.
From the data I just presented, we use different methods for sequencing. We use whole exome sequencing, we use genotyping, and for the polygenic risk score, actually, we do a validation from a different cohort in different hospitals. So we have the confidence that with the higher polygenic risk score, it is associated with higher prevalence of disease. And for other parts, maybe for the HLA deep sequencing, we have two sites from our hospital and from another China Medical University hospital. So we could validate each other. But I believe this question is very important because we don't want to make mistakes.
Okay, and let me just follow up with that. So these are commercial kits that you use, and you do an internal validation before you do your testing?
Yes, yes.
Okay, thank you. All right, any other question, please just type on the chat. While I'm waiting for that, I just have a question. In terms of the pharmacogenomics you mentioned, I'm assuming in Taiwan or within your health system, you have generated some sort of a gene drug database. And I'm just thinking, how is this used? Can it be used for outpatients or is it limited to inpatient when you look at drug selection based on the alleles that you have in the patient?
Oh, I would like to thank you to bring up this question. Actually, in Taiwan National Health Insurance, we just covered two pharmacogenomics markers. One is HLA 5801, and the other one is HLA 1502. Okay. This is for the allopurinol and the tegretol. And for these two drugs, actually in my hospital, if the doctor wants to prescribe the drug, the system will pop out or alert to see whether the patient has been checked for the HLA typing. And if not, we cannot prescribe the drugs. So it is a safe measure to prevent Stevens-Johnson syndrome for those patients who may develop severe drug allergy when they carry these two HLAs. But for different other part of the pharmacogenomics, like TPMT, CYP2C19, they all come in a self-funded method. So the patient must pay from their own pocket.
Okay. And I assume that the patient will be advised based on the cost-benefit ratio.
Right.
Yeah.
You're
Okay.
right.
Thank you. All right. So one more question here. I think I'll just take this before we move to the next speaker. So Alfonso, you're asking that she saw from your tables. And the question is around genetic testing. Can it aid in the diagnosis of periodontitis? Or as you have mentioned, detect risk in healthy patients or certain population? Specifically looking at
I'm not quite sure in which slide I mentioned the periodontitis.
Yeah, I don't think you did, but yeah, but
let me try to respond. Periodontitis is actually quite important in the initiation of rheumatoid arthritis.
Yeah.
There has been various reports showing that the germs in the gingiva, actually they contain the enzymes that can situate certain antigens in the blood. So it is the initiator of ACPA, anti-citrullinated peptide. For the diagnosis of rheumatoid arthritis, we usually check the ACPA, anti-CCP antibodies. So periodontitis is very important. For our study, when we do a GWAS, we will put several covariates into the GWAS. The age, gender, the periodontitis, and also the BMI, PC for covariant. If we do the GWAS for rheumatoid arthritis, this is my quick response.
Yeah, I guess that's and of course you mentioned this periodontitis also an inflammation. So I guess specific testing needs to be tailored towards that. Thank you so much, Dr. Chen, for your time. Because of time, we have to move on to the next speaker.
Thank you.
Thank you so much. All right. All right. So I'm going to just go on to the next speaker as the organizers prepare the slide for the next speaker as I introduce the next speaker. Okay. Okay, so the next speaker is Dr. Amanda. I'm going to stick to Amanda. Okay. She's the chief at the Division of Medical Oncology and the CEO in charge of Precision Medicine Center, Cell Therapy and Regenerative Medicine. She has a PhD from the School of Medicine, China Medical University in Taiwan. And she's our postgraduate education and training has also been in hematology and medical oncology. Okay, please make welcome Dr. Amanda as she makes her presentation. You're welcome to take the floor. Over to you.
Good morning, everyone in University of West and Dr. Chen, and our project is the Precision Medicine Department of Oncology. Yes, and today I will try to want to take away. Yeah, today is the era of gene-guided therapy. But for medical decision, it's important how we apply the molecular result to patient treatment. Today I will show you what is molecular tumor board, the importance of molecular tumor board, and second, the process of molecular board in my hospital in Taiwan, and typical platform of molecular in my hospital. Yes, and yes, our hospital located in Taiwan, and Taiwan outside of mainland China. Yes, we have the 1,600 beds, and average 6,000 newly diagnosed cancer patients per year. And what is the molecular tumor board? It is a special multidisciplinary team, and many focus on using molecular and genetic information to arrange personalized cancer treatment plan. And we know that for few patients with genetic mutation, have guidelines suggest the target therapy, but most of patients do not have. So we have to learn from prior experience of similar patient. So when we met, it's a major change is to realize the primacy of precision medicine is no longer institution. So we need a team. And so we need a bridge. What is our bridge? Current anti-cancer treatment and the genetic and molecular tests are necessary for us. The treatment team also offers the therapy choice to patients. But how can we choose the information to guide the treatment? Molecular tumor goal is a bridge, especially when difficult to treat patient. And the Taiwan first and TV start with the TNU that have three affiliated hospital. In 2017, the program is supported by its president of TNU, Professor Yan, and I was in charge of this project. In 2019, another family cancer genetic program started in TNU, and in 2022, yes, I moved to the Taichung Veteran Hospital and also start the NTV and supported by our superintendent, Professor Chen. And next year, the government project, Cancer Precision Medicine and National Biobank, also Taiwan started in Taiwan, also in TCBGH. And it's our online. I will show you our current situation and outcome with our hospital and our workflow and some multiple and the cash sharing also introduce the clinical planning. And most of our NGS was done in our hospital. Most comes from the genetic test company as the foundation one medicine. And most of the case, cancer we test is lung cancer and also including the colorectal cancer, pancreatic cancer, esophageal cancer, gastric cancer, breast cancer, biliary, colorectal cancer. And also in our precision medicine, we also do WS and Gen9 and hereditary cancer panel. And every this in recent year, we have about 300 cases how we do in this year. We also have down the over 100 case in our precision center. And so the funding of NGS was partially from our government project. And also partially paid by patients, the pockets. And the more we discussed, and in these 2 years, it's the 119 cases. Also, yes, we are lung cancer. And so the second one is gastric cancer and pancreatic cancer. Yes, this kind of adoption rate, how we suggest the primary physician choose around the 42%. Due to most of the case we discussed, no guideline driven treatment. So most patient use accept the treatment is the clinical trial, now part from the company and part from our government project, and others are the available use paid by patients' pocket money. And how we get the data? Yes, we know the cancer from the first line and the later line we use the shorter of progression-free survival. So if we suggest patient the treatment, the patient have longer progression-free survival than last line. So we maybe this suggestion is beneficial for our patient. And so we collection most of the patient was lung cancer, and also we discussed gastric cancer, pancreatic cancer, and most of the patient are stage 4 disease. That 16 patients, and also we know that the portrait was around the 42%, and whose progression-free survival to average is the 129 days, and we know longer progression-free survival 2 than pre-progression for survival 1 is around the 48%, but we know that is the longer selection bias. So overall response rate, patient have a clinical benefits. Ours is 44 patient, and most of patient is a partial response and spatial disease. We know that data yes is a selection bias, because if patient they don't have the we can from actionable mutation, or we cannot suggest from the mechanism of the mutation. We did not discuss the likelihood if patient only have TP53 mutation. And I will show you our precision oncology workflow. Yes, when we page the primary physician, yes, they discuss with patient, they know this patient need to do the NGS, and we give patient the informed consent, then order the test. And this order will be the sample will be reviewed by our pathological department and cover the sample. The size is enough for the DNA or RNA genomic analysis, and then send to maybe outsource to external vendor or our precision center to do tests. Get result maybe 3 to 4 weeks. And then we have the NGS report maybe by primary physician request to NTV scheduling, or maybe pick up by maybe choose by our molecular tumor morpholysis interesting case. So we discuss the molecular tumor form to discuss that. If we have any actionable drug or any recommended drug, maybe coding by the mechanism, we give the physician suggestion. If no drugs, or maybe sometimes we will also discuss the kind of chemotherapy or receptor. And every molecular tumor we will hold up every 2 weeks, and we also follow up this kind of patient the outcome every 6 months, because we know most of patients we suggest is the off-label use, so we need to follow up their outcome. And then we talk about the molecular tumor goal. Yes, the purpose of molecular tumor goal is the most for clinical physician. Yes, we also most of we serve the clinical physician. Yeah, maybe give their consultation, what kind of test, and maybe this patient, we suggest me to do the hereditary cancer test, and maybe help to interpretation test. But for the physician or patient, they maybe really they actually want to know the kind of treatment and suggest and sequence of treatment. And sometimes they match any clinical trial can refer. But for us, we know that this information and treatment is also still new for us, and still a lot of the new treatment comes from. So we need to have the education for our medical team. And in our hospital, we every 2 weeks we have a molecular tumor goal. Every case we need to spend 30 minutes to discuss. Every time we discuss 1 to 3 cases, and we also follow up the patient outcome every 6 months. And also in our member molecular tumor goal, yes, most of it. But in Taiwan, sometimes maybe the chip is some medical oncology, some for maybe the pathologist or more molecular pathologist. Yes, we also include medical oncology, pediatric oncologist, radiation oncologist, and because we discuss most of these lung cancers, we also include pulmonary oncologists and other related primary physicians. And also is that most important the pathologist and researcher, cancer research center, and the biomedical scientist, pharmacist, and if a patient maybe hereditary cancer disease, we also have consult the genetic counselor will also join this meeting. And the most important, yes, we need the case management or coordination. And so in guideline, molecular tumor in Taiwan also have the molecular tumor guideline. Yes, we several hospital yes, have the molecular education and the academic hospital. We have this kind of meeting and choose the what kind of member should be included in molecular tumor board. So it's almost the same as our hospital. It's including primary care physician, clinical oncologist, pathologist, expert in molecular pathology, case manager, and pharmacist. And maybe also with for the purpose of maybe discuss before or after the treatment, sometimes for suggestion, sometimes for application or follow up. And what kind of the yes, we think that all the NGS should be discussed in the molecular tumor board, but we know we don't have so much time. So most we agree is the yes, if our patient have a mutation of taking clinical application or those days the peer approval approach are available, other oncology tumor should be discussed in the molecular tumor board. And we show some of the case. Yes, it is. We know the pancreatic cancer is difficult to treat. The cancer is a 60-year-old woman. Yes, she received operation, but unfortunately, recurrence after operation. She has lung and abdominal lymph node metastasis. First time she received the typical treatment, gemcitabine and ovume-based castle. But 3 months later, disease progression. And secondly, she received the guideline treatment in Taiwan, like a stromal irritant and 5U. But 4 months later, disease progression. Then she received third-line treatment as starting and WebU. 4 months later, disease progression because NGS in pancreatic cancer is not paid by government insurance, so patient check do the NGS in her third line. So we found that she has the atypical BRAF mutation. So we also discussed what kind of treatment she suggests to choose. After treatment, we suggest you and with the primary physician, we use the chemotherapy and BRAF inhibitor. And in this meeting, before that we discuss the mutation we found in pancreatic cancer, and also the NGS report, and with this kind of BRAF mutation, maybe the Cas2 mutation, and is the mutation is every report to have some kind of the functional change. And also in pancreatic cancer, if the patient has this kind of mutation, so we find out the treatment and suggestion. So give that. Also, before this case, they will discuss this patient. She was cured by the operation, but we found that she had because it's so young, it's 25 years old. So we do the NGS, we find that maybe have to check to the mutation, the kind of mutation. So we also discussing and also suggest to do the family genetic test. And also is another pancreatic cancer. We also discuss the clinical and pathological and genetic the reports. And also discuss that she has the oncogenic mutation, and also discuss the treatment, and we have series reports. But we know that it's a generic, but we have all the discuss. We have give the primary vision, the suggestion, and discuss the mechanism. And we know that molecular tumor board is spend much time Yeah, so we have long time to prepare that. As it has a menu process and many these files is set together. So it really for physicians joining the molecular is really workloading, get really burned out. Yes. So we want to use digital approach. So we use the NGS report that can auto catch the this kind of PDF genetic test into the our asset to natural profiling, and also catch the not only the main mutation, also BUS and the EBF and many tail the mutation. And also now the genetic mutation also patients summary, staging cancer, and the clinical information and some kind of treatment patient receive that before, including not only the drug, also the operation radiation. And also we know that this kind of, and also this report sometimes we know that current NGS and this provider also suggest some kind of treatment. So also recorded in our digital plan feed. And also we give the what kind of treatment. We know the date, start date and end date. And also if you want to collect this kind of mutation, or collect this kind of the patient, we also use the filter to collect this kind of mutation patient data we can analyze. And also if you have completed the discussion, we have print out the PDF that and give including the meeting discussion. And it's our whole process. We this adjacent report and also including clinical information and human information, and also into the digital plan feed and the data to help us prepare the slide and the final the meeting report. And today I want to know is we know this is the area of gene-driven therapy. So it will help us to choose medication because we also learn from this kind of the targeting treatment. Yes, also we discuss available use. Yeah, so it gives ideal clinical trial. Also, we know this has spent a lot of time and physicians don't have time. So we especially the digital plan feed to help us saving preparing time and help us to manage this database and set your attention. Yeah.
Thank you. Thank you. Wonderful take-home message from Dr. Amanda. And I want to thank you for this elucidating this collaborative management of oncology patients and to improve their at least prognosis and the outcome. And I think I've learned quite a lot from this. Yeah. But before I get into my conversation, if you have any question from the attendees, please, colleagues that are on the call, please put it on the Q&A. Okay, just one from Monji already. Okay.
Okay.
The NGS report. Yeah, can you say that? Okay, cool. Go ahead.
The first question. Yes, the NGS report including only WES. No, most of we do maybe like the from the company, so not the most of we report not the WES. Yes, so we discuss comes from the maybe foundation one and very few from our precision medicine. So most of we discuss the not WES. Yeah.
All right. Monji, I guess you're happy with that response. You can follow up if you're not. All right. Any other question from the colleagues? Okay, while people are waiting to type, I'm totally impressed with the last part of the presentation, particularly because I was wondering at the middle of how does the MTB review, outcome, tallies with the number of cases that you have to deal with, and in order for you to make efficient decision. If you look at the people that are waiting in line for you to make decision, and you mentioned at the end that you're now digitizing the process. So just one question from that in terms of how often do you use the outcome from a particular review, from previous review, to inform new cases from your digital optimization that you're doing right now? Did you get my question, Dr. Amanda?
Can you explain more detail? Follow your question?
Do you want me to repeat that?
Yeah, please. Thank you.
Okay, so I was just asking that I can imagine it's very difficult for the MTB to be reviewing so many cases and all the cases are waiting in line. And you mentioned at the end that you're now trying to use digital platforms. So my question is, how often do you use outcome from previous cases to inform new ones? Maybe decisions you've made in the past, and how do you use it to make new ones? Is my question clear?
Also use the outcome old ones to inform new ones.
Yes, because we just start the MTV for 2 years, because so we some maybe suggested by experts, because we have the many members, so we still remember that. But in the future, we have the plan to use the previous data to establish the is aim of label use guideline to future patients.
Okay, that'll be so nice. Thank you so much. Any other question from colleagues? All right, I don't see any other question. Thank you, Dr. Amanda. I think in the interest of time, we might have to move on to the next presenter. Thank you so much. Pleasure having you. So colleagues, we move on to the next presentation, the third one for this morning. And that will be by Dr. Okay, now apologies for this. That should, my best pronunciation is Zhu Ong, if I get that right. Okay. Okay. Yeah, I see I pronounced it. All right. So just a background on the presenter. Okay. He was an associate research fellow at the Department of Medical Research at the Taichung Veteran General Hospital. Then he went on to do postdoctoral fellowship at the Department of Medicine, National Taiwan University. Currently his research interest is in bioinformatics, system biology, computational biology, and of course, looking at the NGS data that Dr. Amanda just spoke about now. So I guess the bioinformatics in the house will be looking forward to your presentation. So please take it away. Thank you so much.
Thank you for the invitation of the University of West. This is my honor to show some of our results of the project Taiwan Precision Medicine Initiative. And this project is the Precision Medicine project in Taiwan, totally about more than 30 hospitals joined that. And there I will talk about our experiment in our hospital. Okay, this is the endpoint of the Taiwan Precision Medicine. We want to hope everyone can have better treatment and health management. So our hospital joined the Taiwan Precision Medicine Initiative program about 2019, and then time we discussed the operation project. And for the project is raised by academic syndicate. For them, it just aim to collect the DNA, genetics data, and the medical record for do some research. But our hospital is hospital side, and we also try to implement some precision medicine into the clinical practice. So when we try to join this program, we try to return some of the research results to the patient they enroll in this project. So we try to deliver back some genetics results, some locals, some oocyte have already associated to people's health, and try to deliver the information back to the participant and help them to promote their health. And for this project, totally, the TPI project collected about 500,000 participants involved in this project. And in my hospital, Taiwan Veteran General Hospital, we totally collected about 100,000. And this is our base data to analyze, and cooperate with the data from medicine. Because we try to return the result for participants, so maybe the participant got their genetic information, their question. So we also try to provide the medicine counseling to answer their question if they have any question about their genetic data. For some patients, the result shows they have some disease associated, inheritance disease associated to the genetic locus that we need to provide outpatient, specific outpatient clinical to help them to treat the disease. And this is the totally participation procedure of a patient. When patient come to the outpatient clinic, our physician will invite the patient to enroll in this project. And then we will automatically print the consent form with the QR code. If the patient want to join the program, they will sign the consent form. Then a process order will generate. The patient come back next time, they will do the blood draw, and the blood will send to our central lab of the Center of Precision Medicine. Then do the DNA extraction, the gene expression microarray treatment. Then we will do the analysis after 12 months. We will deliver back the genetic the result, the return of the result to the participant. If they have any question, they can make a phone call to our precision medicine counselor. If they have some inheritance disease, they can come to our outpatient clinic. So this is the overall flow chart that we do to perform the precision medicine project to recruit the participant for our patient and provide the health care service for them. This is the clinical array we used in this project, and the top one is QR screen. This is for research purpose. We look for the new locus, new genetic marker to associate with this. And the others, they also have the disease-related variant, also include the cancer variant, and also other functional variants, such like the immunotransplant, the radial variant, the pharmacological variant. So this array is designed for multi-purpose, also include the research and the clinical utilization. So at that time, we try to pick up some variant in this array and some informative variant and try to deliver back to our participants. And finally, we select the 9 locals to try to deliver back to our participants. One is ALDH2. This is about the alcohol fresh syndrome, and also about the FEO, is about the BMI, and the ABCG2 is about is associated with the gut, and also HBV and the familial hypoglycemia and the disease we call the cardiosis, and also to the pharmacogenomics genes. And one is TPMT, as mentioned as Dr. Chen in the previous talk. And at that time, we just collect those variants from the literature. Actually, we don't know the real prevalence in Taiwanese people. So when we collect about almost 10,000 patients, we start to analyze our data. This is about 3 years ago, and then we saw the data. We was very surprised. For example, for the alcohol fresh syndrome, for the variant I671, we up to 7.8% got homozygous. For the hyperuricemia variant, we up to the 10% participant with the homozygous. And more importantly, for the disease, familial hyperglycemia, we up to 0.9% have the carrier. So it means we have the almost 1% people have the disease with the high cholesterol. And we also have other disease called the cachexia, the carrier rate is up to the 1%. And also we got the MODY, the early onset diabetes about the 0.1%. And so when we try to deliver back the result, we start to think that we need to do some research about those variants because the frequency is very, very high and they are very affect the Taiwanese health. Now, and we also observe some pharmacogenomics team, for example, CYP2C19, the poor metabolites up to the 40%, and for people use the clopidogrel must affected by this variant, and it means the up to the 14% of people use the clopidogrel is the efficiency is very, very, very low. And also the TPME, the Dr. Chen mentioned in previous study that we got about the 0.04% with the poor metabolites and the 2.8% got in the metabolites. But those data shows that genetic variant is affect the Taiwanese health a lot. So now we try to do some research, we dig those information more. If the more information we dig in, and we find out that we can promote the Taiwanese health through the genetic testing. And today I will introduce the familial hyperglycemia, and this is the mechanism of the LDL degradation. In our liver, the circulation LDL will bind into the surface receptor called LDL receptor. Then the LDL receptor will go inside the liver to do the degradation. We also have another gene called the PCSK9. The PCSK9 will bind into the LDL receptor to avoid LDL binding to LDL receptor. So this is the positive regulation to degrade the LDL, and this is the negative regulation to avoid the LDL degradation. Through the mechanism, we've got a balanced level of the low density lipid in our blood. According to literature, at about 2013, at that time, they think the familial hyperglycemia is about the frequency up to the 0, and every 5 people got the 1 heterozygous familial hyperglycemia. And at that time, the information, the data shows if you got the heterozygous familial hyperglycemia, the LDL level is up to more than 200. And the data shows in the 50 years old, you have the 5% chance to get the CAD disease, and the 3 main genes, LDLR, ApoB, and the PCSK9 mutation was involved. This is the familial hyperglycemia. And for homozygous familial hyperglycemia is very, very rare. The frequency rate almost that in 1 million people got 1 patient. And the data is from another physician, Dr. Lee. So according to the data from 2014, since the people got we call the heterozygous FH, the LDL level is more than 200, and for people got the homozygous FH, the LDL level is up to 500. Why this disease is very big important? According to the field, the data from the 2013, when people accumulate the LDL up to the 150 grams, you will meet the threshold of the heart disease, have a very, very high chance to get the heart disease. For general, the hyperglycemia without the genetic defect, when people more than the 55 years old, we all reach the threshold. But if you are the patient, you are the carrier of familial hyperglycemia, you will reach the threshold about 35 years old. So in Taiwan, we got a very early onset heart disease. We now guess the name made associated to this disease, familial hyperglycemia. So because we see our first data from the 10,000 people, we find that the prevalence is about 1%. Every 100 people, we got one familial hyperglycemia patient. So we do the case control study. At that time, we already collected about 42,000 patients, and we through the data analysis, we got about close to 400 carriers. We do the case control study and collect close to 4,000 patients without the gene mutation, and do the comparison. And we find that we got about 200 people with the LDR mutation and 150 people with the ApoE mutation. Then we perform the PWAS. The PWAS means for the case control study, we compare the medical record in our outpatient medical record in our hospital and do the comparison between the carrier and the non-carrier to see which disease is enriched in carrier group. And we find as expected, the patient with disorder of lipid metabolism and hyperlipidemia also has cardiovascular and also MI. But this is expected for the patient with the FH should have. And then we also compare the data from the MVP program. This is the data from the United States. It's a median veteran program. And the data shows the similar pattern for the patient with the FH carrier. They also have the disorder of hyperlipid metabolism, hyperlipidemia, and atherosclerosis and MI. So since the FH carrier in Taiwan and in United States share the same symptom and the disease in hospital, but the difference is, and for the right side data from the MVP program, you can show they got a lot of the PCSK9 mutation. The people is up to the more than 1,000. So the most mutation of FH from the United States is PCSK9 mutation, and then followed by the ApoE mutation. Then the third one is the LDR mutation. But in Taiwanese, the most one is LDR mutation. Then the ApoE mutation. We don't have any PCSK9 mutation. So all for the FH carrier, the symptom is the same, but the genetic mutation pattern is different. For the United States, USA people, the most mutation they have is PCSK9, but for Taiwanese, we don't have PCSK9 mutation. Most mutation we have is LDR mutation. And in the previous, all familial hypocalcemia is diagnosed through the clinical symptoms. So we got many people identified as the familial FH, and we put that together and call the familial FH. But we know that if you mutation in the different gene, in different position of the gene, you should have different percentage to affect their function. So the level of the FH is different. So we try to analyze and divide the disease into the locus level. We can show that for this locus, IS2A9, for this locus, their LDL level is much more higher than other locus. For example, for this locus, they have a more high odds ratio to get the MI than other locus. So based in the previous, without any genetic information, we only can put all the patients into the one category we call the. Now we have the genetic data. We can divide the patient of familial FH into the different molecular subtype, and the different molecular subtype have different level of the effect of their LDL level. Because the FH is highly associated to the LDL level, and the LDL also be one of the most important risk factor of MI. So we try to investigate. So what's the association between the MI and the FH? So we collect about, in our data, we collect about close to 7,000 patients with the angiography, and about the 8% patients have LDL level up to the 113. For them, we collect about we select close 285 NI patients to detect the NGS panel, and the 41 of them was identified as the FH, and the percentage up to 14.4%. And we analyze the data for the MI patient. We find that for the carrier FH carrier have more chance to revascularization in their follow-up. We also do the multivariate analysis and it shows that even we consider LDL level, the carrier status also as another risk factor. And we also surveyed the FH carrier percentage in our stroke patient, and we find about 10% patient with the high LDL level in the stroke was FH carriers, and the overall cohort, the stroke cohort, about 5% of the patient was FH carrier. And through the data analysis, we showed in the first one, the large artery atherosclerosis stroke patient is highly associated with the FH carrier, and those patients, the FH carrier have previous the CAD and the CVD the history, and also have the more thick intima thickness. So those data shows that because the general population have up to 1% FH carrier in Taiwanese, and our data shows for MI patient and the stroke patient, FH is a very important risk factor, and this disease is preventable. So we can propose, we can do the preemptive test to find out all the FH carrier in Taiwanese, and to do the treatment for their LDL to control their LDL level, then we can prevent the disease progress to MI or stroke. This is what we try to do in our precision medicine or prevention medicine setting. And as Dr. Chen mentioned, we try to do a genetic report and promote the genetic test in our health well check, and help our people to do the genetic test and find the genetic disease and do the prevention to avoid the more serious disease happen. This is my last slide. I think the area of precision medicine is coming. The sleeper rate is quite cheap, and add-on array, the whole genome sequence is very, very cheap. Everyone the price is affordable, and everyone will have their own genome information in the future. I think in this decade or next decade, everyone will have their own information, and that will impact the health system. And in the PPMI project, we use the sleeper array as a screen tool to screen disease. As the example I showed as FH, we can find out a lot of the FH carrier and understand the FH carrier have very, very high chance for the disease of MI and stroke. And for those patients, they need to control their LDL level very aggressively to avoid the disease. And to perform the project, we needed the multidisciplinary cooperation to cooperate with the clinical medicine. The people work together with the education, counseling, and the case management. And as it showed, as Dr. Chen talked in the NTP, the cooperation and the discussion board is very, very important for precision medicine now in both in the oncology and the genomic. And thank you for your listening. Thank you.
Thank you so much. It was quite an interesting presentation. Thank you for all the data and the studies that you show. And I agree with you. I'm looking forward to the day when we all have a barcode and you can read off my genomic information, my metabolomic, proteomic information before you start treatment. Yeah. Okay. Questions from colleagues, please just type on the chat if you have any questions. I'm just going to give you a couple of minutes for that. If you have any questions, please type on the chat. While I'm waiting for the question, I'm just going to ask my question. So I'm looking at the, interestingly, the FH and LDL relationship that you showed to relate to the cardiovascular heart diseases. And I'm looking in general, genetic profiling and affects preventive medicine. How much encouragement is given and how much support is given by the Taiwanese government to make people actually go for this testing in order to be able to, at least we can begin to triage the people that we know at higher risk and begin to implement some preventive medicine. So how much encouragement? Yeah, go ahead. Please go ahead.
Can you repeat your question?
So how much encouragement is given, or how much support is given for this genetic testing by the government? Or is it something due to the individuals?
Oh, yeah. Yeah, I think now I think that the most issue is about money, the budget.
Is money, yeah, I understand.
The budget. I think that if we can find a more important evidence in such large project, then we can do it. The government, okay, you need to do that. The investigator for the research is important. Then you try to do that. And now we try to find more evidence. Try to persuade our government. Hey, you need to give the government insurance to provide all kind of tests to promote our health and save your insurance cost. This is now we try to do that. We still work on it.
Yeah, I agree with you. I agree with you. So I guess it's our challenge as researchers to show to the government that it's cheaper to prevent a disease than to treat a disease. That is our job, and I think we are all on the cost to that. Yeah, it might be cheaper. All right. Any other question from the house? I don't see any on the chat. Okay, Monji has a question. Okay, so he's looking at legal framework for implementing precision medicine.
Is the region further in medicine? Okay, this is a very, very good question. When we perform the PPMI project, I think our legal framework is not work yet. But now that we try to make a new law to regulate genetic label and more than 1,000 people how to regulate. But now the law, I think the law will become true this year or next year. So this is another question for research guy, always too much behind about the law, and still with some time for government to perform a law to protect people, don't use the genetic, use the genetic information in the right way and not in the wrong way. We still wait for that.
Yeah. So just to follow up on that, so within your private hospitals, do you see a lot of uptake of this implementation precision medicine for people that can afford it? Do you see them doing it a lot already?
In our private hospital, some people already do that. But we are public hospital, so we need to follow the government.
The government. I see. All right. Thank you so much. So we look forward to that framework, and maybe so many other countries can copy from Taiwan. All right. Okay. So we're moving, colleagues. We're moving on to the last presentation. Now let me just pull up my. Okay, that should be Dr. Yang, I believe. Okay. He's currently the director of the Minimally Invasive Neurosurgery Department at the Neurologic Medical Center, the Taichung Veteran General Hospital, and also Deputy Director of Cell Therapy and Regenerative Medicine. Remember, our topic today is precision medicine and regenerative medicine. and is as a doctor of philosophy at the Graduate Institute of Medical Science, the National Defense Medical Center, Taipei in Taiwan. Thank you so much, Dr. Yang. Please, you have the floor.
Okay, thank you for your introduction. It's my honor to be here to share our experience to use stem cell to treat a spinal cord injury patient. Here is the content for the talk of today. Okay. First, I have to introduce what spinal cord injury is. Actually, statistically, there are about 180,000 new individuals each year. So that maybe 1.3 million person suffer from spinal cord injury worldwide. We can say there are 20 new cases per million population every year in Europe, Taiwan, and Hong Kong. If we have spinal cord injury, the spinal cord will suffer will encounter the mechanical force directly on the spinal cord. So we divide it into 3 phases. Acute phase from the injury lasts to 48 hours, maybe last 4 days, and followed by subacute phase from 2 days to months, 2 weeks, and it also can last 2 months, and followed by chronic states. We can see the picture here. The mechanical force directly the injury occurs here, and then the inflammation process was activated, and so immune cell will infiltrate the spinal cord, and after the inflammation process subside, the angiogenesis will occur, and the scarring, glial scarring, would formate, and followed by the structural tissue regeneration and become chronic stage. Okay, so what we need in spinal cord injury, in different phases, the primary injury occurs, the spinal cord injured, the damage happened. We surgical intervention to do the adequate decompressive surgery is necessary to make a large wound for the spinal cord to get the time to be take rest and reduce the secondary injury. But for sure, the secondary injury would occur, including an inflammation process, neurodegradation, degeneration, and a blood-brain barrier, can say blood-spinal cord barrier dysfunction, and neuronal death, demyelination, disruption of nerve pathway. For this, maybe we need to find some method, some way to solve this kind of problem, like tissue protection, immunomodulation, acid regeneration, and myelin regeneration. So we found that stem cell can help us to do this. Okay, so there have been already many scientists or neurosurgeons to try to develop this kind of treatment, like implantation of stem cell. Once we want to implant the stem cell, hopefully we need the cell have some function. Like if we implant cell, hopefully we need them to survive longer, and the differentiate into neurons, glials, and we need the stem cell have the host cell to derive the exon. We need to relay the injured the host cell to connect both ends of the injury site by stem cell. extend the host spinal cord. And we need them to maybe secrete some growth factor to help the host cell to regrowth or regeneration. Okay, so there are many different types of stem cell we can get right now, like mesenchymal stem cell. We can easily get a stem cell from bone marrow and umbilical cord and amniotic adipose tissue. Also, we can get from embryonic stem cell, induced pluripotent stem cell. There are many ethics issues here, so we don't use this in Taiwan. The stem cell here can do many things like immunomodulation and the trophic support and replace the spinal cord architecture and the functionality. Like here, neural stem cell can enhance the T cell function. The mesenchymal stem cell can make the M1 microphage to become M2 microphage and drive dendritic cell to work. So all these can do anti-inflammation function response. And they also can differentiate it into neuron and the vessel. Like here, embryonic cell is more powerful. It can differentiate into neurons and oligodendrocyte to replace the spinal cord architecture and functionality. So as induced pluripotent stem cell, we can reprogram the cells and let them to differentiate into different kind of cells as we wish. So it's also powerful. Also technical, very strict and need more technology. Okay, and so like olfactory sheathing cells and Schwann cells. Okay. Which kind of cell we are currently using in our hospital? We choose bone marrow mesenchymal stem cell and umbilical cord mesenchymal stem cell because it's easy for us to get. According to the pathobiology, we can see the spinal cord injury patient, they will have several things happen in the spinal cord. Vascular defect and related to spinal cord edema, ischemia, and the neural and the glial cell death, and inflammation, and reactive oxygen species, and this free radical and growth factor would be influenced. At the same time, the mesenchymal stem cell have many effects too. They can cover and resolve this kind of problem, like they can enhance the angiogenesis and help the host cell and the vein cell to differentiate into neuron and glial cell. And they can do immunomodulation to overcome the inflammation process and reducing the spinal cord injury to help them do the regeneration. And also secrete the growth factor and to help the host cell to do regeneration. We can see there have been a lot of paper published. About 40% they used autologous bone marrow MSC, and followed by umbilical cord MSC. So the first one is bone marrow MSC. The second place is umbilical cord MSC. Why they choose this? There are several simple reasons here. Bone marrow MSC capable of differentiating into neurons and the glial cells. and reduce inflammation reaction and astroglial scarring density. Umbilical cord mesenchymal stem cell, they show low immunogenicity because there is very low or no expression of human leukocyte antigen typing. Okay, and they can also differentiate it into multiple cell type, including neural-like and glial-like cells. Okay. Cell preparation, I will go through this very quickly because we cooperate with some company. The company will offer us the high quality cell and the validated cell. Safety assessment and the cell identification will be done before the cell can be used on patient. So the flow cytometry analysis to make sure they are qualified, meet our requirement. They are real stem cell, like differentiation assays and G-band karyotype analysis. Okay, the cell number and the apply route. We can see there were many studies had already published. The most important thing is safety. Before we use this kind of cell to treat patient, we need to know the safety to whether it's good, safe for the using the patient. So review the paper, we can see with a maximum of 6-year follow-up and the procedure-related complications were minor and temporary, so it's safe. So we start to do this, and then we need to know how many cells is suitable for us to treat this kind of patient. So there were many different sites currently or already finished this kind of study, many papers published, but we can see here about n times 10 to the 7 or 10 times to the 10 to the 8. The cell amount should be more beneficial for treat a spinal cord injury patient. And the RCT research in 2013, they say multiple site injection would be better than single site injection. The other paper published show this multiple site injection. The right side, you can see different suggestion here. The left side is our protocol at our hospital. We do the bilateral, upper, middle, lower. Each point we do superficial about 3 millimeter and the deep 6 millimeter injection. Totally, we injected 1 times 10 to the 8 cells to separate to 12 injection sites. Which clinical stage targeting? Okay. Actually, there are already many papers published. We can say if we do the cell implantation directly at the acute stage, it won't be good because the inflammation circumstance and there will be many toxicity there. The mesenchymal stem cell would be hurt and leading to the cell death. The dead stem cell would release more toxicity and exactly worse the spinal cord injury condition, worsen the condition. So we go back to the cascade here. We can see acute stage is not suitable for us to implant the cell, but subacute status meet our requirement because there are 2 reasons. Because we need working time for cell preparation, and we don't like to inject the cell too late because the severe gliosis already occurred. So the most critical stage that meet both conditions, it should be subacute stage. Combined therapy. We need to say each kind of stem cell has its own unique capacity to like differentiate into different kinds cells and different ability to do immunomodulation. So if we can combine several different kinds of stem cell may offer more benefit result for the patient. And the biomaterial scaffold, if we use this, maybe we can keep the stem cell live longer and can work well, combined with growth factor, may help the cell stay longer there. There are also some paper published say that if you implant a cell at the Q space, would get the best result. If you want to treat a chronic phase patient, monotherapy is not enough. So they combine many different kinds of stem cells to treat this kind of patient, and got satisfied result. Okay, limits of stem cell obviously is very it has a limitation. The most important thing is if we can have optimal therapeutic protocols. The most important things too, we don't have yet. Okay, because we need preparation, different kind of injury and a different kind of cell, number of cells we need, and timing to implant a route of administration, like intrathecally, systemically, or directly into damaged site. Engineered biomaterials like hydrogel fill the irregular conformation of the lesion cavity, may provide a good condition to let the stem cell live longer and work well, something like this limitation. Okay, the advisory protocol. Actually, we do have two kinds of cell using in our hospital for bone marrow BMSC. The first, we do the compression surgery, and the subacute stage, we got the stem cell from patient, and after this, about more than 6 months, we do one single implant to the spinal cord, 1 times to 10 to the 8, and the long-term follow-up. For umbilical cord MSC, the same. We do the one implantation in the injury site, and followed by monthly intrathecal injection and follow-up. Okay, that's our selection criteria for BMSC more than 6 months, CT to T2, and the HRA. If not, we will do the compassionate therapy and use MSC. Okay, after the treatment, we would like to evaluate the effect. So we use clinical pain measure and McGill pain questionnaire, and for standard ASIA, the grading, and before surgery, before treatment, 6 months, 12 months after treatment. And also SSEP, tibial nerve for lower limb and the median nerve for upper limb. And the urodynamic test. Okay, finally, I will present a case. A 45-year-old male, traffic accident on February 8, 2021. He got the injury from C3 to 7 spinal cord injury. HRA, muscle power grade 0 for legs, grade 3 for 4 of right arm, right, and the grade 3 of that upper extremity. We do the intralesion injection with 1 times 10 to the 8 cells on October 30, 2023, and followed by monthly intrathecal injection. And present the 8 months after treatment, we'll show you. You can see the patient got a muscle power improved, grade 4 of bilateral upper extremities, and the grade 0 the same for legs, but regain the light touch sensory. MRI of C-spine, you can see here. Left side before surgery, the syringomyelia, the necrosis site, and after the treatment for 8 months, you can see the the injured site recover. And the axial view you can see here, the irregular conformation of the necrosis site. And after treatment, you can see it got improved. The necrosis area decreased. Here you can see left side, the patient 6 months after treatment. The muscle power of upper extremity improved, but he couldn't stand. He needs somebody help to hold him to keep stand. And right now, 8 months after treatment, you can see, although he still couldn't move his leg, but he can stand without help, without others' help, and he can stand by himself. Okay, this is my last slide for summary. The role of mesenchymal stem cell in the treatment of spinal injury is promising. It can achieve immunosuppression, reduce inflammation process, and release neurotropic factor, regular signaling pathway. The effect of mesenchymal stem cell therapy reported in the literature is not sufficient to make conclusion. There are many things not yet to know well. We need to do more clinical trial to try to know this well. So anyway, I think it's a good way for us to treat spinal cord injury patient. Thank you for listening.
Thank you so much. Thank you. We appreciate that presentation, and this is a new dimension looking at regenerative medicine. So colleagues, questions from our colleagues. Once again, you can type on the chat. Monji has a question already. So he acknowledged the excellency of the presentation and asked a question why most of the cited studies are from a specific region. You're talking about the Middle East, Iran, India, the rest. What are the legal and ethical limitations to the use of this technology?
Actually, I think it should be the government policy, because I don't know for Middle East, for our country, there is a very strict regulation for us to do this kind of treatment. So we have already tried to do this for 5 years, but we just started this kind of treatment for about 1 year. So it's there include many ethics issues because we need to get the cells and do something that God does. So maybe, but in Taiwan, I think the regulation is strict for us to do this kind of treatment.
Okay, that's well taken. Any other question from the colleagues? So yeah, it's something that I believe every government needs to look at on case-to-case basis, especially that is needed. Colleagues, any question? Okay, can I just ask, so once you implement this treatment, if you look at one of the limitations that I've read is the fact that some of the cells might, because they're grown over so many generations, they might become cancerous. Are there post-treatment to limit the chances of those stem cells getting out of control?
There already some case report. When we implant the stem cell, it might have a chance to become cancer cell. Yes, there are some case report published. Yes, so that currently there are many different sites. The scientists try to use exosome to decrease the inflammation process. Exosome like a paraffin from the stem cell, and they can offer the same ability to do the immunomodulation and reduce the inflammation process. Yes. So at the same Yeah, and some different I know from some like Japan, they do iPSC. They will keep eye on this to see the follow the stem cell growth differentiation. They have some their way to do that.
That's comforting. That's very comforting. Good. All right. Any other question from the colleagues? Okay, if there are no other questions, at this point, I think my job is done. I'm going to hand over to Clement to wrap up and to appreciate all the presenters at today's webinar.
Oh, thank you, Samuel. I would like to thank our colleagues from Taichung Veterans General Hospital for taking your precious time from your work treating patients just to come on this webinar to share the impressive work that you are doing in this area of precision medicine and regenerative medicine. So I would like to thank Dr. Yi Ming Chen, the first presenter, and Dr. Hui En Zheng, the second presenter, and Dr. Tu Hung Xiao, the third presenter, and finally, Dr. Meng Yin Yang. We really appreciate you and thank you for taking your time to present to us the work that you are doing. And I also want to thank Mr. Lai at the Computer Communication Center and your team for this connection. And we believe that it's the kind of connection that will lead us to more possibilities. And to all of us who came to attend this presentation, I would like to thank you all for staying in, taking some time off your work, especially in morning hours like this. I really thank you. And finally, before we close, I would like to ask Dr. Lai maybe to say a few words. Over to you, sir.
Okay, thank you, Dr. Clement. Thank you, all audience, our guest speakers. I think I'm very sorry because I have another meeting just finished, so I came back to this meeting. I think today we invite four most significant speakers from our hospital. The topics cover precision medicine and regenerative medicine. I hope every audience can get more information and knowledge from our speakers. And if you have any, if the UWC or any colleagues have any problems or you want to cooperate with Taichung Veterans General Hospital, we will arrange further cooperation between us. Thank you. Thank you for today's arrangement. Thank you.
Thank you so much, Dr. Lai and your team. And as he has mentioned, if there is interest in collaboration or maybe need to find out more, you can contact us or even contact them directly should you get their email or contact details from the presentations. And for us, we will be able to facilitate the connection, because the purpose why we do this is so that we should know what is happening on the other side of the world and look at possibilities of working together and collaboration. So having reached this far, this is the end of our presentations. The video of the webinar will actually be uploaded on YouTube in the next few days. So thank you very much. Wishing you a great day ahead. Thank you. Share.
Thank you. Thank you. Thank you. Thank you.
Thank you.
Thank you.
you all. Bye.